Thanks very much. So, yeah, my name's Suren Shanmugasunderam or Shan, and I do comprehensive ophthalmology in Vancouver. So that's kind of anything that comes in the door. So I see kind of regular eye disease. Most of my surgical stuff is like cataracts and like laser refractive surgery. So thanks everybody for kind of coming on tonight. And I figured I would just get right into the pre-submitted questions. And if anybody has any follow-ups or anything as we go along, just let me know, and then we'll kind of open it up to any questions that you guys have. So it was kind enough that the questions that were submitted were kind of thematically grouped. So we had glaucoma as our first one, and Lon R asked, "What is the effect of type 1 diabetes on retinopathy and glaucoma?" So there's no direct link of type 1 diabetes on glaucoma, but some of the things that we do to treat, particularly things like Avastin injections and some of the surgeries like vitrectomies, can accelerate glaucoma progression and can cause people to develop glaucoma. And glaucoma does not tend to accelerate diabetic retinopathy. So those two diseases tend to be fairly independent. They don't tend to go together. Um, we had our next question, which was how does the glaucoma get diagnosed? So going back a step, glaucoma is damage to the optic nerve, the nerve from the eye to the brain. In most people, glaucoma is associated with increased pressure in the eye. So it happens because the high pressure interrupts the normal blood flow to the eye. There's about a quarter of people that have what we call low tension glaucoma. So your pressure is normal, but otherwise it's exactly the same. We think that what happens there is that you just have blood vessel disease. You have narrowing of the arteries and decreased blood flow, even with kind of a normal intraocular pressure. So we diagnose glaucoma by looking for signs of damage to the optic nerve. So we look at your optic nerve. It kind of dies in a very characteristic way. It's called cupping. So the center of the nerve kind of dies off, and you get a bigger and bigger hole in the center. We do ancillary testing, OCTs and HRTs to sort of map it out. But at a fundamental level, we look at how much nerve tissue is there and whether that's normal. We look at your visual field. So that's the function part of things. So we look to make sure there's no loss of your peripheral vision. And then we finally check your intraocular pressure, because whether your pressure is high or low, that is the only thing we can currently treat. We do not have any, we know that other factors are involved. We talked about blood flow. We have no therapies for them. So whether whether your pressure is high, medium, or low, our goal is to drop the pressure more because it's the only treatable risk factor. So we kind of measure all of those things to kind of diagnose glaucoma, and we actually measure the same things to see if it's progressing. So we look at your field, your OCT, and your pressure. Treatment for glaucoma. So generally, treatment is drops. 90% of people are on eye drops that reduce your pressure. About 10% wind up having laser trabeculoplasty. It improves the drainage part of the eye. Very few people these days have open glaucoma surgery. We call it filtering surgery. It's basically like a coronary bypass. We make a hole in the eye so fluid can drain from the inside to the outside. Problem is, of course, that hole can get plugged up. It's a easy way for infection to get in the eye. So it has a reasonable kind of risk of failure and complications kind of every year. Prevention. I wish I could tell you there was any good prevention. There is not. Similarly, glaucoma is like high blood pressure. You got to screen for it because symptoms happen late, and we can't undo damage that's already happened, only kind of prevent further damage. But for all of you guys, you're all getting your eyes checked once a year, I hope, and so you're going to get screened for glaucoma along the way too. So it's not something that you have to do specifically other than have your eyes checked, and you're having your eyes checked, that'll be checked as well. Ooh, and we had a question of, is glaucoma directly connected to MD? Um, are you talking about mean deviation on the field? Is that what you mean by MD?
Macular degeneration.
That was Ed Hennon? No?
I'll just unmute here just a minute. And
Uh,
can you hear me now?
I
Yep.
can.
Yeah, macular degeneration.
Oh, I'm sorry. So we generally abbreviate that AMD, age-related macular degeneration. No. So macular degeneration and glaucoma are the two most common diseases of the elderly in terms of eye disease, other than cataracts, and they are separate. There's a lot of comorbidity, so a lot of people do have both. But they are quite separate and they don't tend to interact with each other. Other than the fact that I tell people glaucoma nibbles away your vision from the outside in, macular degeneration from the inside out. So if you have them together, that's a bad combination because you kind of are losing vision everywhere if they're progressing. So that is a bad combination of diseases to have. The last question I had under the glaucoma category was, are there any cautions I need to consider future cataract surgery and most likely glaucoma? So I guess if the question is, do you already have glaucoma and you're going to have cataract surgery? Generally, the answer is no. There are some types of glaucoma that make cataract surgery more difficult, but generally, about a third of people we do cataract surgery on, their pressures just get better just by doing the cataract surgery. That lasts for a few years. You can combine glaucoma surgery with cataract surgery in people that need better control. So generally the answer is no. And then the question of, does cataract surgery lead to getting glaucoma? And the answer is generally not. So cataract surgery doesn't increase your risk. If you already have glaucoma, cataract surgery generally doesn't make it worse, and sometimes it makes it better. So that was our list of kind of glaucoma questions. And I don't know if there's any kind of follow-up questions on glaucoma at the moment.
I don't see any in the chat here, but I will let you know if any come through. And then also, as I mentioned in the chat, please feel free to unmute if it was your question asked, or if you just have some questions afterwards as he's going through them. But if you'd like, we can move through to the next little section here, which is surgery.
Sure. So the first question I have under surgery is from Alicia D. Is there laser treatment for eyes for diabetes? So I presume you're talking about diabetic retinopathy. And so going back to the 1960s, that was actually the very first treatment that we had for diabetes, for diabetic retinopathy. So there are two major things that we treat in eyes with diabetes. The first is called macular edema. So you have fluid leakage in the center of the eye, which causes the light receptors to get kind of wavy and distorted. And we would laser the leaking areas, the leaking blood vessels. And then the second is proliferative retinopathy, where you get so much damage to the blood vessels that you don't get enough oxygen delivery and you get new blood vessel growth. The problem is, and we're going to keep talking about this, the new blood vessels are abnormal. They leak, they bleed, they make things worse. And so we did what's called pan-retinal laser, where we destroyed a lot of your peripheral retina to try and preserve the blood flow for your central vision. So those were the first treatments for diabetic retinopathy, and they are still used to some extent today. Going on to kind of the second question of Avastin, a lot of patients these days are getting Avastin in addition to or separate from their laser therapy. Avastin and the drugs like it block something called vascular endothelial growth factor. It's something tissue makes when it's being starved of oxygen. It's a signal to your body to grow new blood vessels. But as we said, the vessels are abnormal, they make it worse. Avastin actually sort of stops that from causing new blood vessel growth. Our second question was, I'm getting Avastin injections every 3 months. Is this a lifelong treatment? So the reason why we do all of these things, laser or Avastin, is because there's vascular damage happening to your eyes with type 1 diabetes. Vascular damage, if your blood sugars are out of control, if you have other vascular risk factors like hypertension, high cholesterol, smoking, the usual list of things, will continue, and you wind up on medications kind of for a lifetime. What we hope is that you, in combination with your endocrinologist or your GP, can kind of reduce all of those things that are causing damage. So better blood sugar control, better blood pressure control, better cholesterol, all of those things, so that the rate of damage slows down. And if that happens and it's below the rate at which your body can heal, then you can get off the Avastin and things are stable. There's no way to tell for sure. And so what winds up happening is that the duration of time between Avastin injections gets lengthened. And generally, by the time you hit 3 or 4 months between injections, we're pretty comfortable that, hey, things are quiet and you can stop. So Avastin is kind of like the finger in the dike. The ultimate answer is always about vascular risk factors. And if you can get those better, you can get off the Avastin. If you can't, you can't. The third question I got about surgery is, I'm recovering from surgery for repair of a hole behind the eye. Could my diabetes have contributed this to occurring? How are holes behind the eye prevented? So I presume you're talking about a retinal hole. Retinal holes happen in two locations. One are peripheral, the second are central. By and large, retinal holes happen because of traction, because the jelly that fills the inside of the eye tugs on your retina, and if it tugs hard enough, it can tear a hole. If you have new blood vessel growth or bleeding inside of the eye, that can cause scarring. That will cause tears. But by and large, the majority of holes that we see are not related to bleeding or tearing or anything else, and it's just an aging process. So 1 in 10,000 people per year get a retinal tear. Macular holes are a little bit less frequent than that. And they're by and large just anatomy and bad luck, and is not related to other health diseases or really anything that you did. Generally speaking, the retina guys, if they fix one hole, will look in the other eye and will treat anything that looks like it's at risk. So there's nothing lifestyle-wise that you can do, but definitely you would want to make sure with whoever repaired the one hole that they've looked in both eyes and treated anything that's in both eyes. That was the end of our surgery questions. I don't know if anybody had any follow-ups on any of those questions. If not, we'll move on to dry eyes. Ooh, my favorite. So I joke about it because dry eyes is really common. And I have dry eyes myself. It kind of happens as you get older. Our first question is, while my optometrist says there's no significant change in my vision, I can hardly see because of blurriness. I have very dry eyes, don't enjoy reading anymore. I've had cataract surgery in both eyes several years ago. Should I be seeing an ophthalmologist again? I think that's my optometrist says he should be the one who refers me and is reticent in doing so. So again, if you roll the clock back 20 years, dry eyes was use your lubricating drops, and that's the end of it. Thankfully, the pharmaceutical companies have spent a fair amount of money and research time to actually find some better answers for dryness. So the answer is, we don't have perfect answers, but we certainly have more answers for dry eyes now than we did in the past. I kind of lump dry eye treatment in 4 big categories. Tear replacement, that's artificial tears. If you've ever looked in the pharmacy, there are absolutely racks of artificial tears. And the reason is there's no perfect answer. The newest ones are ones that are thickened with like hyaluronic acid. There's a few different brand names like Hylo and Theolaz and Soothe. Um, and if you have dry eyes and you aren't comfortable, those are kind of worth a try. If you're stable, stick with what you're using. We have medicated drops that increase your tear production. So that's Xiidra and Restasis. They do need to be prescribed for you. They take a few weeks to a few months to sort of see the full effect, but they do work really well in people for whom lubricating drops aren't cutting it. We can plug your tear drainage system. So the tears you make, the drops you put in, drain through little openings in your lid into your nose. And if we plug it up, then it lasts longer. Downside is you can get more tears running down your cheek because it can't drain into your nose. And then it's environmental modification, things like humidifiers and stuff. So certainly your optometrist is able to prescribe those medications. They can kind of walk you through it. But if you've kind of tried a lot of them and you don't seem to be getting any success, absolutely going back to see your ophthalmologist, either from your optometrist or your family doctor or your endocrinologist or any of your physicians as a referral is reasonable. Ooh, we got a macular degeneration question snuck in there. So difference between wet and dry macular degeneration, we might as well deal with it now. So macular degeneration is a wear and tear change of the light receptors in the back of the eye. So again, one of the most common eye diseases people get as they get older, most common cause of visual loss in the elderly in North America. There's a genetic abnormality in people who get macular degeneration. What happens is that when you use your eyes to see light, there's a bit of damage that happens. Your immune system fires up, cleans it up, shuts down. In people who get macular degeneration, your immune system doesn't shut down properly. And so you get this low-grade inflammation that causes damage over years. So that's basically the dry form. Your body tries to fix it by, guess what? Growing new blood vessels to try and make things better. But also, guess what? They make it worse. They break, they bleed, they cause problems. Same sort of story we were talking about with diabetic retinopathy. Your body's repair mechanisms actually make it worse. So that's wet macular degeneration, new blood vessel growth under your retina. Wet macular degeneration, we can treat reasonably well, meaning it has to be caught within the first couple of months of starting, because once it scars, the light receptor is gone, you can't do very much. So the signs of wet macular degeneration are a sudden change in vision in one eye, distortion, big blind spots in your central vision. Anything like that, you got to get it checked out within a couple months. We do injections, Avastin, same stuff we were talking about before, stops new blood vessel growth to treat wet macular degeneration. That's the difference between wet and dry. About a third of people with macular degeneration eventually get the wet form. So it's actually a pretty big number. And then the final question under dry eyes was using Maxidex ointment for iritis that an ophthalmologist put you on. I read the side effects are serious. Is there a better medication? So iritis, the problem is untreated inflammation in your eye. Iritis is, well, there's a comment, I'll come back in a second. Untreated iritis can cause cataracts and glaucoma. Too much steroid can cause cataracts and glaucoma. So the problem is that both the treatments and the disease can cause the same issues. So what you have to do is titrate, pick the amount of steroid to keep things under control, to minimize the effects from that and minimize the side effects from the medication. So yes, the person who's seeing you is the best one to sort of go, are you on too much, too little? Is that okay? Do you need to stay on it forever? Can you kind of taper off? Those are all really valid questions to ask whoever's treating you. And from the same person, there was, can you speak about dry eyes? What can happen if they don't attend to them? Is Sustain a good choice? Kind of touch base about trying the ones with hyaluronic acid. That's not Sustain. But having said that, lots of my patients are on Sustain, works great. And there's no particularly increased issues with type 1 diabetes and dryness, except to say eye surgeries of any kind, injections, cataract surgery, vitrectomies, laser, all tend to make your eyes more dry. So, I mean, if you have had multiple eye procedures, that does tend to do it as well. If you have significant neuropathy, that's an issue because the reason that you blink is because you feel that your eyes are dry and uncomfortable. And if you have decreased corneal sensation, you don't blink. And if you've got dry eyes, that makes it worse. So the worst combination is always dryness with decreased sensation in the eyes. And obviously, neuropathy is associated with diabetes. Those usually peripheral neuropathy. It's unusual to have corneal anesthesia from diabetes. And the last question in there was, can you get a cataract more than once in the same eye? And the answer is no. You only get cataract surgery once. About half of people, the bag that we put the lens implant in gets hazy, and we do a laser to fix that. Some people call that an after cataract, but it's a completely different procedure. You don't have to go into the eye. It's kind of like a little office thing. So no, you'll only have cataract surgery once in your eye. You may need a laser afterwards, usually a few years afterwards. Sort of getting back to the question that was asked there, we had a few here. So, do the warm pads from the optometrist on the eyes help with dry eyes? So, your tear film is fairly complex. It's got a water layer, an oil layer, and a mucus layer. And so we kind of talked about the water part of things. A lot of people have dry eyes because the oil part of the tears doesn't work very well. And our treatment, and that's associated with acne rosacea, like adult onset acne on your face. And rosacea, or oil gland dysfunction, we treat with warm compresses, lid hygiene, omega-3 fatty acids, and sometimes oral antibiotics. So if you have dryness because of oil gland dysfunction, absolutely the warm pads make a difference. Someone asked, is macular degeneration hereditary? Absolutely. So we talked about the basic science behind that, but if you have a first degree relative with it, there is an increased chance that you will get it, unfortunately. My optometrist told me that my dry eyes were because of plugged tear ducts, probably plugged oil ducts, not tear ducts. And so that's the massage that you were talking about. Big part of the problem with screen time. Yeah, I mean, when when you look at dry eyes, it's what's going on with your eyes, and then it's what's going on with the environment. So if we all lived in Hawaii, we would not have dry eyes because we'd live in a warm, kind of humid environment. If we lived in Vegas or Calgary, we would all have dry eyes and it would be way worse. So that's one part of it. In Vancouver, dryness is worse in the winter because the heat's on. In the summer, particularly now that we're having smoke. And the more you have your eyes open, the more they'll dry out. And when we concentrate, when we read, when we use a screen, we don't blink as often because your brain wants to not miss something. And so the more you concentrate like that, the more dryness you get, which is also why dryness is worse as the day progresses. Most people, they're fine in the morning. It gets worse over the course of the day. They're like, hey, it's fine on the weekends. So yes, you generally have to do more on days where you're doing more with your eyes, and when the environment is dry. Good.
All
Any
right.
other follow-up? Sorry.
Oh, no, I was just saying I don't see any more follow-up questions in there for the
All
dry
right.
eyes questions, but I will open it up for if anyone wanted to unmute. But if not, then we can get into the next one, which was eye health. I see Stephanie's raised her hand. Go ahead.
Shit. Sorry, no, I didn't realize there was another bunch of questions, Caleb, so you can continue with the next batch.
Oh, okay, great. Go ahead.
Sure. And for anybody who didn't pre-submit questions, we'll have lots of time at the end to kind of get your questions. So yes, please do ask those. Eye health. So somebody asked if there are supplements that we should take for eye health. So the only thing that's been shown to make a difference is for treating dry macular degeneration using oral antioxidants help. So remember we were saying it's like sun damage and then sort of ongoing immune activity. they're working on specific treatments to target the immune part of things, but targeting the sun part of things is what we do at the moment. So if you have dry macular degeneration, or if you have a risk of getting it, meaning that you've got a first-degree relative with it, we tend to encourage people to take antioxidants. You can get antioxidants in your diet from things like oily fish and greens and pomegranates and blueberries and pomegranates, blueberries, tomatoes. If you don't eat those things regularly, you can take a multivitamin a day. This is pretty old news, and so the multivitamin manufacturers have it in there. And then there's specific eye vitamins like Preservision, Ocuvite, Vitalux that do this. So for macular degeneration, supplementation with antioxidants has been shown to make a difference. There's nothing else that supplementation has made a difference for. So it doesn't help prevent cataracts or anything else going on with your eyes like glaucoma. Sun protection is also something that we kind of tell people to do. That's really the best thing that you can do for the health of the eyes, is to wear appropriate sun protection. People always remind me it's winter in Vancouver. We're not going to see the sun for 2 or 3 months. So this is mostly if you're traveling someplace tropical or in the summer, you don't. So, and somebody asked lutein. Lutein is an antioxidant. And so absolutely, lutein fits into those antioxidants and is a good choice for slowing the progression of macular degeneration. Omega-3 fatty acids fit into there as well. When should you be concerned about your eye health? I mean, vision is the eye vital sign. So just like, you go to Emerge and they will check your blood pressure and your heart rate and your respiratory rate, because that tells you something about how you as a person are doing. Your visual acuity is the most important vital sign for your eyes. So making sure that your central vision and your peripheral vision are kind of normal and that you've got no distortion or kind of stuff like that. And then finally, comfort of the eyes, which is, are they red or sore or irritated? Those are primarily the things that you're looking for in terms of eye health. We had a question about the stuff in eye drops, and that's hyaluronic acid. So that's HYALURONIC. So just to go back, I mean, our eye drops used to be thickened with wood fiber, cellulose, and hyaluronic acid is made kind of by genetic engineering techniques, and it's a more animal kind of form of thickener. So you can splash water in your eyes or salt water and that'll work, but it won't last very long. So both the cellulose and the hyaluronic acid are ways of thickening the drop so that it lasts longer. And the hyaluronic acid is the newest one. Just because it's newer doesn't mean it's better. If you're having success with what you're using currently, don't change it. But if you want to try something, if you're not having success, absolutely. Recommendations on tips to increase blood flow to the retina. Unfortunately, no go. So the reason why I say that, so your retina, like your brain, is very tightly controlled in terms of blood flow. So your body defends blood flow to your brain and your eye at the expense of every other part of your body. And so there's really no good way of increasing blood flow because your body really will do that until you die. That's its absolute kind of last thing that it will kind of succumb to. So nothing that you do is going to change that, because if you try and increase blood flow elsewhere in your body just will constrict the blood vessels and reduce the flow to your eye and your brain. So recommendations for ophthalmology care in pregnancy. I see people kind of really every trimester during pregnancy. Having said that, if you have no diabetic retinopathy, the chances that you're going to go from 0 to anything visually significant over your pregnancy are minimal. So, I mean, in people who have no findings, probably fine to do regular care. As you guys probably hear, type 1 diabetics, after 10 years, 100% of people have some findings. So this is primarily for the type 2 diabetics that we tend to be a little bit more laissez-faire. Certainly as a type 1 diabetic, and especially if you have some changes every trimester is kind of the recommendation. There was a question about side effects from eye drops. Anything you put in the eye is gonna cause you trouble. So, um, uh, artificial tears, preservative-free artificial tears, are just like salt and water and thickener, and people still find that they kind of sting a little bit as they go in the eye because the pH is different and the osmolality is different, and they're cold and kind of all that stuff. Um, so generally speaking, the nastier the drug that we give you, just like anything we put in your mouth, the more side effects that you're going to have from it. So some of the glaucoma drops are particularly nasty. We know them chemically to be nasty, and they're going to cause more stinging. But if you're using something for comfort, an artificial tear, it should overall be more comfortable when you use it than when you don't. So if and no, there's no long-term side effects from using artificial teardrops. Some high-low tends to come preservative-free. Some artificial teardrops have preservatives, and some people, over years of exposure to preservatives, do develop a hypersensitivity to them. So that's the only downside. And if you do get it, what you do is just stop using that preservative, and you can use a different type of preservative or preservative-free. So no, using lubricating drops does not make your eyes more dry. That, I think, was the end of our eye health bit.
We just had one last one in there. It was just at the end, and it says, I have very slow growing cataracts. In the next few years, will there be many choices for replacement lenses?
So our biggest limitation these days with lens implants is focusing. So we can set your eyes comfortably for either distance or close. We can correct astigmatism, but we don't have lenses that accommodate, that focus so that you can see both distance and close. People have been working on lenses that accommodate for a couple of decades, and it hasn't really panned out yet. We have compromises we can do. We can set one eye for distance, one eye for close. Affects your depth perception. We have multifocal lenses. They affect your night vision. So the bulk of people today still wind up with both their eyes set for distance and needing reading glasses. So, I mean, in terms of taking the cataract out, we still are using the same technology that's been refined, that's been around for 30 years, because new stuff has come and gone that has not given us better results. Lens implants are where things are likely to change, and if we do get an accommodating lens, that would certainly be the holy grail, because people wouldn't need reading glasses. So nothing in the immediate pipeline. Good. So I was going to move on to diabetes care and eye health. Does hypoglycemia affect the health of the eyes? Yes. So, I remember kind of when I was an intern, you'd have people coming in seizing from hypoglycemia, and you'd give them a shot of D50 and they'd kind of wake up and happen. So brain and retina, retina is an outpouching of brain. It only lives on glucose and ketone bodies. And if your sugar level gets too low, it does not do very well. Retina, like brain, does not store extra energy in there. 35% of your brain, of your body's energy use goes to your brain and your eyes. So a ton of your body's energy expenditure is because of brain and eyes, mostly brain. And if it doesn't have enough sugar, it doesn't work very well. So if you have repeated episodes of hypoglycemia, you will start killing off both brain tissue and eye tissue. So yes, one bout of hypoglycemia isn't going to be a problem. Repeated bouts of hypoglycemia, absolutely. It's worrisome. Our next question, as a person with partial low vision due to diabetic neuropathy, maybe retinopathy, maybe neuropathy, how does someone get signed up to learn about new studies? Your best, there's a couple of ways to go about that. I mean, your eye care provider can generally tell you if there's something kind of relevant to what you're doing. Probably about 5 or 10 years ago, the American National Institutes of Health started a registry for all randomized trials that are kind of being performed in the US. And generally, if it's being done globally, it's going to at least have a portion being done in the US. And you can actually search that up. So you can search up the registry of trials that are currently going on. And this is every trial, not just eyes, not just diabetes. And I haven't done it for a couple of years, but I'm pretty sure you can search by keywords and kind of, look to see. So you can do that yourself by actually looking at what clinical trials are enrolling. It's a lot of work. There's a lot of studies, as you might imagine, going on. Usually the best answer is to ask your specialist. So if it's diabetic neuropathy, your neuro-ophthalmologist, or if it's diabetic retinopathy, your retinal specialist to see if there's anything kind of going on that would benefit you. And then our last question in there is blurred sugars when blood sugars are high will better control health risks. So the reason why your vision changes along with blood sugar is that the lens of your eye is alive. The lens cells also live on sugar. And so sugar kind of gets into the lens, it gets tagged with a little phosphate group, and then it can't get out of the lens. So if you've got a lot of sugar going on, more sugar goes into the lens and it swells. And so then you get more short-sighted. And then as the sugar goes back, that sugar can't leave. And so you stay short-sighted until it slowly gets broken down and your lens kind of comes back down to normal. So fluctuations in blood sugar cause fluctuations in your prescription and hence blurry vision. And if you have this happen often enough, it's kind of like, bending your kind of door or something, it'll crack, right? So you can get cataract changes from kind of repeated bouts of sugar oscillation. So yes, absolutely, better blood sugar control. So stable, kind of flat blood sugar control is what we all kind of aim for because it's better for all parts of your body, lens included, vision included. So I think that was all of the pre-submitted questions that I saw. And if there's no follow-ups, if anybody has any live questions, I'd be happy to answer.
Right. I do see it's a comment from Ed saying this has been exceptionally informative. Thank you. I wish I'd heard this long ago. And yeah, again, if you'd like to put your question in the chat or ask live right here. Yeah, Stephanie?
Yes, hi. Thanks, Caleb. So yeah, my question is, so I'm involved in a lot of like diabetes health promotion and, trying to get people's blood sugars under control as I live with type 1 and I also work in the health and fitness industry. And I'm part of a bunch of different forums, and I've been hearing that people who have a sharp drop in their A1C lose their vision. And when I'm saying sharp drop, I mean they're coming from either 10 to 12% down to 6% in a very short period of time, short being, I guess, stay within a 6-month period. And so if we are to be health crusaders and helping people to get into control, first of all, why does that happen? And second of all, what would be safer, a safer decline?
Well, this is a bit reminiscent of when I was training, there was this big discussion about whether better blood sugar control was actually a good thing for people, because when you got people's sugars under good control, everything got worse. Their retinopathy got worse, their nephropathy got worse. And it's like, hey, is this a problem? Well, the problem is that you've been causing all this damage. You get the sugar under control, the damage is continuing to occur until that new sort of level kind of takes effect, and all the old damage works its way out of the system. And so we unequivocally know that better blood sugar control makes for less complications. And it's the same with the vision part of things, right? So same thing, you go from out of control. So if you think about it, it's very symmetrical to someone who's newly diagnosed with diabetes. The sugar goes from normal to high, their vision gets all fuzzy because their lens changes shape, and you get it back under control and their vision doesn't fix right away. It takes a bit of time. And that's exactly what's happening here. Their body's gotten used to that level of sugar, their lens has. You drop it down, that's a good thing, but it takes a while for the lens to change shape and stuff to get back to sort of baseline. So the answer is, it's education. It's letting people know, yes, this is going to happen. No, it's not a sign of damage to your eyes happening. It's kind of what you have to go through to kind of get things stabilized. And the benefits of getting that sugar under better control sooner rather than later outweigh the kind of inconvenience. Like, I mean, we can get you contact lenses or temporary glasses or things to kind of make it through that period of time while your eyes are adjusting. So, so no, I mean, there isn't a better way to do it. It tends to only happen in people who have been running those really high A1Cs for a while, like 6 to 12 months, so that their lens is now stuffed full of sugar, and then you drop the blood sugar outside and it kind of warps and distorts. Doesn't happen to people who've had cataract surgery. So, if you've had cataract surgery, it won't happen to you. If you haven't had cataract surgery, it might be just worth warning people ahead so that they don't think something's gone wrong.
So it's not permanent then. It's only a temporary
That's
adjustments
right.
until the eye gets used to the new
The new
substrate,
ambient
basically.
blood sugar. Yeah.
Yeah, okay. Okay, great. Thank you for that.
No problem. We had a question about the types of corrective lenses used in cataract surgery. So there's a bunch. So we have, just in terms of the lens implants, we have a standard lens. So that's paid for by the government. It's called a monofocal. It sets you at one distance. You can pick that distance, intermediate, or close. We have everything else are add-ons. You have to pay extra for it. We have toric lens implants that correct astigmatism. So astigmatism means that the front of your eye, the cornea, instead of being round like a soccer ball, is elliptical like a football. And so if you have astigmatism, you either have to correct it in glasses afterwards, or you have to pay to have a toric lens put in your eye. We have lenses that split the light so that some of it gets focused for distance, some of it for intermediate, and some of it for close. So that's called a full range of vision lens, or a multifocal lens. The problem with that is it splits the most light off, so it gives you the most problems with nighttime glare and halos. We also have, they're called extended range of vision, EROV lenses. So they split a little bit of light off at arm's length, so that you can like read price tags in a supermarket. You can see your dashboard. You can't read up close with those. But the advantage is that they give you less nighttime vision disturbance. So that's the ones you're talking about, are the types of lenses. And then because you've got two eyes, we can fiddle. We can set one for distance and one for intermediate, or one for distance, one for close, or one for intermediate and close. So you can kind of do that. That works best in people who who tried in contact lenses before, because your brain has to adjust to it. And it's hard to adjust to it de novo kind of in your eyes. Um, so, um, so yeah, so that's basically your chance. If we're doing this thing called monovision, we set one for distance and we pick based on what the person's doing, where we set the other eye, because reading is a range and there's no one spot for it. And then someone asked, yep, does vision degradation with high sugars also apply to people with cataract lens replacement? Not so much. So I've certainly seen people with type 1 diabetes who notice a bit of vision fluctuation as their sugars fluctuate after cataract surgery. And probably that's the lens of the eye that's changing. The lens really doesn't respond the same way. The cornea is because the cornea is changing. The cornea doesn't respond quite as much as the lens does. So these big fluctuations tend to be in people who haven't had cataract surgery. And you can get smaller fluctuations if your sugars are out of whack, but they are much, much smaller. Readers. So there was a question about somebody's sister who went on a pump. So reading glasses. Reading glasses is a completely different kind of issue than anything that we've talked about so far. So we call that presbyopia, and it happens because the lens of your eye is alive. It puts down layers like an onion. It gets bigger and stiffer through life. There's a little muscle in the eye that bends the lens to focus it. And so as that lens gets stiffer, you can't bend it as much, and so you can't focus it close. So babies can actually focus to like 5 centimeters away from their eyes. Could you imagine that? And then as you get older, you have to go further and further away. And my patients love to say, it's not that my eyes are changing, it's just my arms aren't long enough. Well, what you're doing is you're pushing your arms out to hold it, and eventually you can't push your arms out any longer. So this is a process that's happened to all of us kind of through life. And when your arms aren't long enough, when the print's too small, then you need readers. There are people working on ways to groove the lens to restore that focusing ability. So that's our reading glasses scenario. We want to be able to get reading back for people who haven't had cataract surgery. That would be by grooving the lens. Don't got it. We'd like to be able to restore reading ability in people who've had cataract surgery by having a lens that actually responds to the muscle in your eye. We don't got it. So for both of those different solutions that we're looking for, but still nothing currently that works. So diabetes probably not a factor in developing that. Perimenopause and dryness obviously will worsen reading, as we kind of talked about up front. So that can be the added issue, but it's joining the ranks of the middle-aged, unfortunately. So somebody asked, you're having changes in your vision, you have concerns, how should you proceed? Waiting time's long. Kind of like everything, you kind of have to be an advocate for your own health, because you're the one that kind of knows that, hey, this is not something I've had before. This is big. It sort of bugs me all the time. So we all triage our patients. So we try and see people that are having more urgent problems sooner. And your family doctor can certainly be your advocate in that matter to kind of get it done urgently or semi-urgently. So, telling your family physician that, your vision's affecting your daily function. You can't drive, you can't work, makes a difference. If you have an appointment and it's way in the future, call the eye specialist and be like, do you have a waiting list? Do you have any ability to squeeze me in on a cancellation? Optometry is another good way of trying to kind of get in faster, because there's generally not much of a wait time to see your optometrist. You do have to pay, by and large, to see optometry, but they can put in referrals and they can actually start the process of figuring out what's going on. So, your family doctor may not be able to know why your vision's changing, whereas your optometrist has the equipment and can do that. So those are kind of the best advices for navigating the system. Advocate for yourself, phone and see if you can get in, and use optometry because there's more optometrists than ophthalmologists.
Wonderful. I don't see any more questions in the chat here, but I will open it up one last time if anyone wants to add something or unmute here. All right. Great. I guess that wraps up the Huddle session tonight. Thank you so much, Dr. Shan, for joining us for the Huddle and sharing your knowledge and expertise on this topic. Stay tuned for next month's Huddle, led by Huddle member and psychologist Crystal, who will be speaking to us on mindfulness practices for T1D. Details for this Huddle, as well as a recording of all of our Huddles to date, can be found on Reach Out, the Huddle mailing, and social media. We're continuously working on improving the Huddle sessions, and we would love to hear from you. So if you do have 5 minutes to spare, please consider filling out the short feedback survey linked in the chat. We look at every single comment, and your suggestions help shape the Huddle. If you are having trouble accessing the survey, you can also contact our Huddle coordinator, Lena, who has been sending you emails. And again, thank you to everyone who attended tonight, and thank you to Dr. Shan. We really hope that you all enjoyed this session, and we'll see you next time.
Bye.
Bye.
Thank you. Goodbye.